Hi everyone. So today we'll be doing HIV and AIDS in children. Okay, so HIV. Let's speak about HIV in children. So in general, the management of specific conditions in HIV infected children is similar to that in other children. Most infections in HIV positive children are caused by the same pathogens as in HIV negative children, although they may be more frequent, more severe, and occur repeatedly. Some infections, however, are due to unusual pathogens. Many HIV positive children die from common childhood illnesses, and some of these deaths are preventable by early diagnosis and correct management, um, or by giving routine scheduled vaccinations and improving nutrition. These children have a particularly greater risk for staphylococcal and pneumococcal infections and TB because of the immune compromisation of these kids. And so saving children's lives depends on early identification, immediate treatment with ART, as and co-trimoxazole prophylaxis for those who are HIV infected. Okay, so if you want to start with a broad term, or the take-home message for this session is essentially that there should be early identification. Once there's early identification, there should also very important be immediate um, treatment for HIV, as well as, let me just see that, okay, as well as prevention, okay, prevention, which is basically prevention of HIV, as well as prophylaxis to prevent further infection. Okay, so it's immediate treatment, and then the co-trimoxazole prophylaxis for those who are infected. Okay, so this is kind of the key um, umbrella things to remember. So all infants and children should have the HIV status established at the first contact with health system, ideally at birth, at the earliest opportunity thereafter. To facilitate this, all areas of the hospital in which maternal, neonatal, and child services are delivered should offer HIV serological testing to mothers and the infants and children. Okay, so first of all, how do we diagnose children with HIV? Okay, so speaking about the HIV, I think we should start off with the clinical diagnosis. Okay, so looking into the clinical diagnosis of HIV, right? So the clinical expression of HIV infected children is highly variable, so it can differ basically from child to child. Many HIV positive children show severe HIV related signs and symptoms in the first year of life, while others may remain um, asymptomatic or mildly symptomatic for more than a year and may survive for several years. So the clinical experience indicates that children infected with HIV perinatally who are not on antiretroviral therapy fit into one of the three categories. Okay, so you have uh, children that have rapid progression, okay, in which sadly most of them die before their first birthday, and they are thought to have acquired the infection in the womb of the mother, in utero, or during the early postnatal period. Then you get children who develop symptoms early in life, okay? Then they follow a downhill course and die at the age of 5 to 3 years. And then you get those that are long-term survivors who live beyond 8 years of age. Okay, and they tend to have lymphoid interstitial pneumonitis and stunting with low weight and height for age. Okay, so basically, we can classify this as clinical experience. Okay, of children who are not on antiretroviral therapy. So just to indicate that, so children basically who are not on antiretroviral therapy, there are three categories, okay? The categories are those with rapid progression, okay, and those that got HIV basically in utero, or they in utero, or during the early postnatal period, okay? And then the second category is that of the middle children who develop symptoms early in life. So symptoms early in life. And then we have the third group of children that are long-term survivors. Okay, but usually these long-term survivors they tend to have a condition known as LIP, okay, which is known as lymphoid interstitial pneumonitis, okay, as well as stunting. So they tend to have certain other conditions associated as well because of the immune compromised state, okay. So we speak about lymphoid interstitial pneumonitis. We speak about stunting, so not growing properly. We speak about low weight. So just see over there. Okay, we speak about low weight as well as a low. So it's low weight and height for age. So it's low weight and height for age. Okay. So yeah, so those are basically the children that are not on antiretroviral therapy. Okay. Now, we should suspect HIV if any of the following signs, which are not common in HIV negative children, are present. So, there are certain signs that may indicate a possible HIV infection. Okay. So, what are those signs? The signs that indicate possible HIV infection. Okay. So what are the signs? So they are the first sign is recurrent infection. Okay, so okay, let me just do okay, there's quite a lot of signs that we are going to cover. Signs that indicate possible HIV infection. Okay. The first sign I'm going to speak about is recurrent infection. Right now, recurrent infection is obviously three or more severe episodes of a bacterial infection, such as a pneumonia, a meningitis, sepsis, or a cellulitis in the past 12 months. So, children who are HIV compromised, they have really, like, very poor immune systems. Immune system is quite poor, so they tend to develop those infections. Oral thrush. Now, what is oral thrush? Okay, let me just take that away. Okay, so oral thrush is basically red and white beige pseudomembranous plaques on the palate, gums, and the buccal mucosa. After the neonatal period, the presence of oral thrush is highly suggestive of HIV infection when it lasts more than 30 days. Despite antibiotic treatment, it recurs or extends beyond the tongue and it presents as esophageal candidiasis. Okay, so it's kind of like white type of things in the mouth. The next one is chronic peritonitis. Okay, um, just move it away. So chronic peritonitis. Okay, and that is basically inflammation, swelling in the parotid gland. It could be unilateral or bilateral, and it's just in front of the ear. And that should happen for at least more than 7 days, more than 14 or more days, with or without associated pain or fever. Okay, and the next one, signs that indicate possible HIV infection is that of a generalized lymphadenopathy. Okay, generalized lymphadenopathy. Okay, so with generalized lymphadenopathy, so again, it's got to do with your immune response, your adaptive immune response. Okay, so it's in large lymph nodes in two or more extrainguinal regions with no apparent underlying cause. Okay, the next one is that of hepatomegaly. So having a large liver essentially with no apparent cause. So in the absence of concurrent viral infections, such as cytomegalovirus. So if there's no cytomegalovirus or there's no kind of infection, anything leading to the hepatomegaly, children which have the hepatomegaly, it's a sign that there's possible HIV infection. Okay, persistent and or recurrent fever. Okay, now so I'm going to speak about. Okay, it's very important to mention the persistent and or recurrent fever. So fever more than 38 degrees Celsius, lasting 7 or more days, or occurring more than once over 7 days. Okay, uh, could indicate that a child has HIV. We speak about now. We're moving on to the brain. So neurological dysfunction, neurological dysfunction. Okay, so progressive neurological impairment, microcephaly, delay in achieving developmental milestones, hypertonia, or mental confusion would indicate that a child has HIV infection. Moving on to other infections. So, speaking about, sorry, herpes zoster. Okay, the herpes zoster infection. So it's the herpes zoster infection, or also called shingles, is a painful rash with blisters confined to one dermatome on one side. Okay, moving towards the skin, we have something called HIV dermatitis. Um, so the word itis obviously mean inflammation or infection. So HIV dermatitis is basically, and derm means skin. So it's a erythematous or red papular rash. So its typical skin rashes include extended fungal infection of the skin, nails, and scalp, and extensive molluscum contagiosum. Okay. Moving on to the lungs, the last one is that of chronic suppurative lung disease. Okay, so we have chronic suppurative lung disease. Okay, so those are basically your all the signs that indicate that a child possibly has HIV infection. Okay, so we start with recurrent infection. So we can start with the head going down. So we speak about the mouth, so oral thrush, the parotid gland, chronic parotitis, then maybe lymph node, generalized lymphadenopathy, recurrent persistent fever, going down to the liver, hepatomegaly. Okay, we're still there with the brain, so the brain neurological function, moving down to the lungs, chronic suppurative lung disease, moving to the, okay, I spoke about the liver, and now the skin. So herpes zoster rash or HIV dermatitis. Okay. Now there are signs or conditions that are specific to HIV children. Okay. So we are still busy making this clinical picture, thinking about this clinical diagnosis. Okay. The next avenue that we are going to explore is essentially that of the certain signs that are actually just like specific to the child with HIV. Okay, so let me just get that out. Okay, so these are signs specific to HIV infected children. Okay, so signs specific to HIV children. Okay, so what are the signs? There are basically five signs or basically like five conditions. Okay. So I would rather call it conditions rather than signs. Okay. One, two, three, four, five. Okay. So the first one, we can start from let me just see. So I'm gonna start from the mouth. So usually sarcoma can be seen. Okay. You would always just start from the lungs. Okay. So the pneumocystis gyrovesi pneumonia, PCP. Okay, so PCP, pneumocystis. Okay, pneumocystis gyrovesi pneumonia. Okay, esophageal candidiasis. Okay, um, so basically esophageal candidiasis. Okay, is basically it's basically similar to the representation of the oral thrush. Okay. The third one is LIP. So LIP you spoke about, it's the where's that now? Okay, it's the lymphoid interstitial pneumonitis. And then we speak now about Kaposi sarcoma. Kaposi sarcoma. And the fifth one is acquired rectovaginal fistula in girls. Okay, so specifically in girls, we have something called an acquired rectovaginal fistula. Okay, cool. Now we're going to speak about the signs common in HIV infected children, but which also occur in ill children with no HIV infection. Okay. Um, so I think we can call this signs in HIV children as well as other ill children. Okay. So there's basically just three categories of this aspect. Okay, there are three categories to this aspect. Let me just erase that over there. Just gonna include three aspects. Okay, cool. The first one is that of chronic otitis media. So chronic otitis media. So basically, it's an ear discharge that's lasts more 14 or more days. Okay, so it's infection in the ear. Then we speak about persistent diarrhea. Okay, so persistent diarrhea, child is losing all those electrolytes. And then the last one is moderate or severe acute malnutrition. Okay, malnutrition. Okay, so as the child is losing all those electrolytes, there's a decrease in appetite. The child is not eating enough nutrients, perhaps not absorbing enough nutrients, thus leading to moderate or severe acute malnutrition. Okay. Okay. So we're now going to the testing and the diagnosis of an HIV infection. So we understand that there are certain signs that indicate possible HIV infection. There are signs specific to HIV children and signs in HIV children as well as other ill children, which can hint to us that, okay, this child now essentially attends to us to doing further investigations. Okay. Now, the next part regarding our understanding of HIV in children, this is when we have early identification. Okay, so now we need to identify. So we still part on identification, and now we're on the testing and the diagnosis of HIV. Okay, so how do we diagnose HIV? Okay, so let me just make that a little bit bigger. Okay, so the diagnosis of HIV infection in perinatally exposed infants and young children less than 8 months of age is quite difficult because passively acquired maternal HIV antibodies may still be present in the child's blood. Okay, and it might give a false positive. Um, because sometimes the mother might be HIV and doesn't mean the child is going to be HIV. Okay. Additional diagnostic challenges arise if the child is still breastfeeding or has been breastfed. Because as we know that antibodies might also flow through the breast milk as well. Although many children will have lost HIV antibodies between 9 and 18 months, a virological test is the only reliable method for determining the HIV status of a child less than 18 months of age. Okay, so basically I think a very important note that I actually want to that we need to remember essentially is that the viral test, okay, um, less than 18 months of age, okay, less than 18 months. The viral test is kind of the most accurate test, okay, where either the mother or the child has a positive serological HIV test, and the child has specific symptoms suggestive of an HIV infection, but the virology testing is available, the child may presumptively be diagnosed as having an HIV infection. So if there are clinical signs and the mother's serology is positive and we don't know yet if the child is really positive by the viral test, we need to treat this patient essentially as having HIV. Okay. Um, so all diagnostic HIV testing of children must be confidential and should be accompanied by counseling as and conducted only with informed consent so that it is both informed and voluntary. Okay. The first one is that of a serological antibody test known as ELISA. Okay, so there are two main strands. The first main strand is the HIV serology antibody test known as ELISA or the rapid test. Okay, so this test for the antibodies is widely available. It is sensitive. It is reliable for diagnosing HIV infection in children more than 18 months. Okay, so remember more than 18 months for the ELISA. For children less than 18 months, HIV antibody tests are a sensitive, reliable way of detecting exposure and of excluding HIV infection in non-breastfeeding um, children. Okay, so more than 18 months, it would be a, like we can say, a definitive, and for less than 18 months. Okay, for less than 18 months, it would basically be just for detecting any exposure. Okay, so any exposure and also excluding HIV infection in non-breastfeeding children. Okay, because obviously in breastfeeding children, obviously we know that there would be antibodies. Okay, so that's the first one. The next one is the virological testing. Okay, let me just take that one away. Okay, so the virological testing for HIV-specific RNA and DNA is the most reliable method for HIV-infected children in less than 18 months of age. This may require sending his blood sample to a specialized lab that can perform this test, although virological testing is becoming more widely available in many countries. Okay. The tests are relatively cheap, easy to standardize, and can be done on dried blood spots. The following assays and respective specimen types may be available. So, okay, so there could be HIV DNA on whole blood specimen or dried blood spots, HIV RNA and plasma or dried blood spots, and ultra-sensitive P24 antigen detection in plasma or dried blood spots. So one positive biological test at 4 to 8 weeks is sufficient to diagnose HIV infection. In a young infant, ART should be started without delay, and at the same time, a second specimen should be collected to confirm the positive biological test result. If the infant is still breastfeeding and the biological test is negative, it should be repeated 6 weeks after complete cessation of breastfeeding to confirm that the child is not infected with HIV. Okay, so if the child is breastfeeding and the test is negative, it should be repeated 6 weeks after completing the breastfeed to ensure that the child is not affected. Because while breastfeeding, there might be right transport of those antibodies. Okay. Now, the results of the virological test in infant should be returned to the clinic and to the child, mother, and kid as soon as possible, but at very latest within 4 weeks of the specimen collection. Okay, so the breastfeeding infant is at risk of acquiring HIV infection. In terms of the breastfeeding infants, now diagnosing HIV infection in breastfeeding infants, what are the things that we need to know, right? What are the key things that we need to remember? Okay, we are kind of still busy with the diagnosis. I'm busy with the diagnosis. I think we can just include it in a side note with regards to the diagnosis. So with regards to the diagnosis, we have HIV in breastfeeding infants. Yeah, I think I took chose the pressed the wrong button. Okay, so yeah, so we spoke about that. Um, so HIV in breastfeeding infants. How do I? Okay, so a breastfeeding infant is at risk of acquiring HIV infection from an infected mother throughout the period of breastfeeding, right? Breastfeeding should not be stopped in order to perform diagnostic HIV viral testing. Positive test results should be considered to reflect HIV infection. The interpretation of negative results is, however, difficult because a 6-week period after complete cessation of breastfeeding is required before negative viral tests can reliably indicate the HIV infection status. Okay, so I think what's very, very important to remember with regards to HIV in breastfeeding infants is that um, two viral tests 6 weeks after the cessation of breastfeeding to rule out HIV. Okay, so it's essential to understand that. Okay, that we should do the viral test 6 weeks after the cessation of breastfeeding to rule out the HIV. Okay, because obviously antibodies can cross during breastfeeding. Okay. Um, so I think in this session, I'm going to end off with the clinical staging of HIV. Okay. So we have identified that this child is HIV. We've sent out the test to the lab. Okay. How do you do clinical staging? Okay. Clinical staging of HIV. So there are 4 stages. So in a child with diagnosed or highly suspected HIV infection, the clinical staging system helps to determine the degree of damage to the immune system and to plan treatment and care for this patient. The clinical stages represent a progressive sequence from the least to the most severe, each higher clinical stage indicating a poorer prognosis. Initiating ART antiretroviral treatment with good adherence dramatically improves the prognosis. Okay, so with this treatment, yes, we provide the treatment. But with the treatment comes, it's a two-way story. The patient also need to, the child, mother, the parents need to, or the caregivers need to assist that child, ensuring the child is taking the medication. So clinical staging events can be used to identify the response to ART if there is no easy access to test for viral load or CD4 count. So usually when we speak about later to determine the response to medication, we usually take the status of the child. We always take the CD4 count as well as the viral load. So the following stage is for use in children aged less than 13 years with confirmed lab evidence of HIV infection. Okay. Um, okay. And then HIV antibodies for children more than 18 months, as well as virological testing for those aged less than 18 months. So stage one. Okay. So we're going to start with stage one. So essentially in the first stage, there are just two um, points in the first stage. First one is asymptomatic. So patient might be asymptomatic. And the second one was that of persistent generalized lymphadenopathy. Okay, persistent generalized lymphadenopathy. Okay, cool. So I said two headings under the first stage. For the second stage, we have quite more. We have 11. So I think what I'm going to do, we can do this, right? So we have 1, 2, 3, 4, 5, 6, and then maybe something like that. 3, 4, 5, 6. There might be a seventh one as well. Okay, so we're going to start with hepatosplenomegaly. Okay, hepatosplenomegaly. Okay, so hepatosplenomegaly in stage 2, obviously an increase in the liver and the spleen size. Papilloproliferative eruptions. Okay, okay, papilloproliferative eruptions. Seborrheic dermatitis. Okay, seborrheic dermatitis. Oopsie, what's happening with that? Okay, cool. And then fungal nail infections. So any angular colitis. So that's in the mouth. And the next one is linear gingival erythema. So obviously redness in the gums, gingival, extensive human papillomavirus infection or molluscum infection. Okay, I think we can make extensive human papillomavirus infection, so extensive HPV, recurrent oral ulcerations, recurrent oral ulcerations. We have parotid enlargement. So, okay. And then we also have the herpes zoster. Okay, the herpes zoster. And then we also have recurrent or chronic upper respiratory tract infection. We have recurrent or chronic respiratory tract infection. So it can include essentially what that include is your otitis media, your otorrhea, your sinusitis that they have two or more episodes in the past 6 months. Okay. Now the next stage is that of stage three. Okay, that's our next stage, stage three. So stage three basically has 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Stage three has 12 possible things. So let's go to that. 4, 5, 6. Okay, the first one is the unexplained moderate malnutrition that does not respond to standard therapy. Okay, malnutrition. So we have given the baby nutrition, but the baby is not responding to the to the treatment. Okay. Unexplained persistent diarrhea for more than 14 days. With unexplained moderate malnutrition. And we have unexplained. Okay, so we have unexplained persistent diarrhea, unexplained persistent fever. Okay, so we have unexplained persistent fever. In stage three, we have oral. So persistent fever is intermittent or consistent for more than 1 month. Oral candidiasis, oral candidiasis. Okay, oral candidiasis. Right. Um, Outside the immune period, we have oral hairy leukoplakia. Okay, oral hairy leukoplakia. We have pulmonary TB, right? So as in concomitant infection, pulmonary TB seen in stage 3 of the of levels of HIV infection. Severe recurrent presumed bacterial pneumonia. Okay, so severe recurrent presumed bacterial pneumonia. Let me just okay. Then we have um, acute necrotizing ulcerative gingivitis or periodontitis. Okay, acute necrotizing ulcerative gingivitis. Okay, and then you have the LIP, which is the lymphoid interstitial pneumonia. Okay, lymphoid interstitial pneumonia. Um, Unexplained anemia. Right, unexplained anemia. Okay, unexplained anemia. Don't know where the anemia is coming from. So that's less than 8. Neutropenia or thrombocytopenia. Okay, so it's either unexplained anemia or a neutropenia less than 500 or a thrombocytopenia. Okay. Then the two last ones is that you have something called HIV associated cardiomyopathy. And you also have HIV associated nephropathy. Okay, so that is stage 3. If you want to move on to stage 4, stage 4 has 3, 6, 9. Yeah, stage 4 has quite a lot of. Okay, stage 4 has quite a lot of complications under each stage. Okay, so the first one is unexplained severe wasting or severe malnutrition. Maybe just gonna mention 10. Okay, so we have severe wasting or malnutrition. We have pneumocystis. pneumonia, so it's the PCP. Can you just double check what PC is? PCP was the pneumocystis child VC pneumonia. Okay. Um, so it's the PCP. There's recurrent. Again, we have recurrent residual bacterial infection. So I'm just gonna say recurrent infections. Okay, the recurrent infections. Then we can say chronic orolabial or cutaneous herpes simplex infection lasting more than 1 month. So chronic herpes simplex virus. And the fifth one we have over here is disseminated to extrapulmonary TB. Okay, disseminated or extrapulmonary TB is a sign of very, very late in stage. Okay, remember the chronic HSV is that if it's chronic orolabial or cutaneous, okay, lasting more than a month. The next one is Kaposi sarcoma. So Kaposi sarcoma is the very stage 4 type of HIV infection. The next one is that of esophageal candidiasis, esophageal candidiasis. Okay, we have symptomatic HIV seropositive infant less than 18 months with 2 or more of the following. Okay, so you have your less than 18 months old child. So 2 or more of the following. So with oral thrush or severe pneumonia, failure to thrive, or even severe sepsis. Okay. The next one we have is cytomegalovirus retinitis. And the last one for the lesson I'm going to remember is that of CNS toxoplasmosis. Okay, so CNS toxoplasmosis. Okay, so there are many more, such as cryptococcal, okay, cryptococcal meningitis. I think that's very important. Okay, I'm just going to include others as well because it's all important. Okay, so cryptococcal meningitis, um, candida of the trachea or the bronchi or the lungs. Okay. Um, the cerebral or B cell not Hodgkin lymphoma. So I'm just going to mention over here a lymphoma. non-Hodgkin lymphoma. Then we speak about progressive multifocal leukoencephalopathy or HIV encephalopathy. So HIV encephalopathy. And your last one is, I think we can just say the rectovaginal fistula, the HIV associated recto rectovaginal fistula. Okay, boom. So that's it. We've ended off with the identification of HIV. So signs indicating possible HIV infection. We looked at the signs specific to HIV children. We looked at signs in HIV children as well as other children. We looked at the diagnosis of HIV, including HIV serology as well as viral tests, and also the clinical staging of HIV. So the stage 1, stage 2, stage 3, as well as stage 4. And that's it, everybody, for your first part of HIV in children.